Very good morning to Thailand from Singapore. Thank you for inviting me to talk on the impact of COVID-19 on surgical services. As a urologist, I'll be sharing the perspectives from my institution, National University Hospital, Singapore. I remember in 2020 debating with Indian urologists on what the impact of COVID-19 on urology practice would be 2 years ago. And now, 2.5 years later, we have a clearer picture, and I'm very happy to come back to talk about this topic at RIAC 2022. What I will discuss will be on the global impact of COVID-19 on urology and perhaps translated to all surgical practice, our initial perspective in 2020. Following that, I will discuss on what are the local adaptations that has been performed at my hospital and how perhaps these adaptations can expand beyond country and specialty boundaries. So the global impact of COVID-19 for urology was published by this group of which I have been included in, and it has been a great privilege to work on this paper with the Euro Social Media Work Group. This was published in the European Urology very soon after the study was done. And this was led by Professor Jeremy Teo from Hong Kong via this social media group that he established. The survey was done via SurveyMonkey on the internet, and it comprises of 55 item questions. The survey was performed over a 1 week period from March to April 2020, and within a very short time, 1,004 urologists was able to take part. As you can see, the participants came mainly from Asia, Europe, and North America, which were well represented. However, there was less representation from South America, Africa, and Australasia. Despite this, urological subspecialties from transplantation, oncology, to benign general urologists were all well represented. This is the outcome which showed from the study. This is the heat map of the world, which showed the reduction in surgeries and outpatient, and it is a reflection of outbreaks in different locations. And at that time, North America, Europe, North Africa, and Central Europe were very badly affected, whereas China and some parts of Asia was less affected. And despite this, there was a global average reduction of 30% in outpatient clinics, outpatient procedures, as well as surgeries. However, as you can see on this chart here, not all outpatient subspecialties were equally affected. In particularly, benign urologic conditions such as BPH, infertility, sexual medicine, and urinary incontinence, their clinics were reduced by up to 90%, and surgeries were also impacted equally. However, oncological procedures, and those including prostate, kidney cancer, or organ-threatening conditions such as ureteric stone, their surgeries and outpatient clinics were reduced by a less significant amount, between 20 to 50%. Here we see the delay in surgeries during the initial period, and up to 30% of operations were delayed by more than 8 weeks or 2 months. So I considered this a landmark paper have several important take-home messages. Number one, it utilized social media and internet network to rapidly present a global picture of the COVID-19's negative impact on urology, and I'm sure in general surgical field this was achieved. It also provided a way or a framework where surgical specialties can meet future challenges, be it infective or other challenges to the specialty. It let urologists or specialists all over the world know that you're not alone, and more importantly, provided information or data to formulate guidance by different colleges or surgical specialties. And here on the right, you see the guidance for surgeons that was released by the Royal College of Surgeons of England during that time. Obviously, there was a need to maintain surgical capabilities, and surgeons are needed to fulfill alternate surgical roles as well as alternate non-surgical roles. But the paper that I was part of also highlighted that initially there was a psychological impact on urological providers in that 50% fear going to work, they fear inadequate protection, and also had to deploy to assist in COVID care. And indeed, one of the list of priorities released by the college was the importance of protecting and preserving the surgical workforce. This point remains important as we come out of the COVID-19 pandemic to reach the endemic phase. Here, I remember in March 2020, when the initial COVID numbers rise in Singapore, predominantly driven by our migrant worker population in the dormitories, I had to forget about urology, don on our PPEs to work in dormitories to look after our migrant workers, to swab and to look after the COVID-19 patients. Now, what NUH Urology subsequently did was to develop some local adaptations to try and negate or manage the negative impact that I reported. And this took place in the outpatient as well as for surgeries and perioperative care. For outpatient, telemedicine was an important development. Here, even before COVID-19, we were implementing a ureteric colic telemedicine service whereby a patient who presents in clinic would go for ureteric colic, would go for their CT imaging, but the subsequent consult for the results of the imaging will be done via a phone consult. We have shown and published this paper in 2021 that the number of unnecessary consultations was significantly reduced by this telemedicine implementation. And this was a pilot study that was done before COVID-19 hit us, as you can see from the dates from 2017 to 2019. But the initial pilot study enables us to rapidly upscale the workflow during 2020. These are the things that we did in stages for the patient, and the ones highlighted in yellow are the important aspects. First, we expanded the indications for telemedicine, which included, in addition to the urethral colic, benign conditions, but also surveillance of uro-oncology cancer cases that are in remission for standard follow-up. Secondly, it is important to implement charges and inform to the patient of a suitable charge, because without charging, this telemedicine workflow will not be sustainable. So charges have to be informed, and billing have to be done, settled off-site, offline, online. Pharmacy also had to be brought into the picture to provide home delivery service, because it doesn't make sense for the patient to not show up for clinic, but come to the hospital to pick up their medications. So this was also implemented. Careful follow-up of this expanded teleconsultation confirmed a 60% reduction in outpatient visits in April 2020, soon after the spike in the COVID-19 cases. But more importantly, it enabled us to increase our billable phone consultations by 10%, 10 times. Importantly, we also ensured that the patient experience is carefully monitored. And 3 months after we implemented an expanded telemedicine consult service, we did a survey and found that the majority of patients were satisfied with the consult, with an overall consultation score of almost 8, with a response rate of almost 80%. And 80%, a similar number, would recommend it to their friends and family. So really, I would say in 2022, telemedicine is here to stay. And in fact, it has been, as shown in this the pictures on the left, expanded to even complicated chronic patients. And our colleagues at the National Center for Organ Transplantation are doing telemedicine regularly. In fact, the Ministry of Health is fully supportive of this and has mandated a course which highlights its use, limitations, and implementation, an online course that has to be taken by physicians who wants to do this telemedicine. And our private physicians are also taking this telemedicine up seriously, for it also expands their reach beyond the Singapore borders. Next adaptation I will talk about are adaptations for surgeries, moving from outpatients. And this has two areas: prioritizing surgeries during COVID-19 and the right siting of patient care. So we published in the Go Journal Urology on a surgical triage resource allocation tool, or what we call the START score. And this is a way of prioritizing our surgical cases during the pandemic. Like many other scores that were published, it prioritized organ-threatening or oncological cancer surgeries over benign conditions. However, unique to our score is a resource utilization score that we took into account surgeries that if they require high resource, intensive care, a long hospital stay, or even multiple blood transfusions, these would therefore have to be deprioritized for these would take up resources that had to be used for looking after COVID-19 patients. As such, oncological operations with short hospital stay would be done more readily, whereas obviously benign conditions, including day surgical procedures, vasectomy, circumcision, would be deferred and kicked down the road. So we were very concerned on how these START score will impact on our urological practice. Here is a paper that published our initial transition from open laparoscopic partial nephrectomy to robotic partial nephrectomy. And we were doing great outcomes, showing a reduction in post-operative morbidity and hospital length of stay, with a subsequently increase in the number of cases through the years in the robotic arm. And very interestingly, we found that despite a COVID-19 pandemic, our robotic partial nephrectomy numbers have risen over the last 2 years. And in fact, in this year, we've already hit our 2021 numbers at mid-year. And really, this may be actually an impact of the START triage, which has been extended beyond the pandemic, because we have been prioritizing oncological operations, kidney cancer, partial nephrectomy, with low resource utilization. The utilization of the robot for surgery facilitated a short hospital stay and therefore lower resource utilization. What about those circumcision and vasectomies? What happens to those cases? Because you cannot kick them out indefinitely down the road. And here, right siting of care is important. And you can see in this graph on the left, we have moved a lot of these minor operations down the road, a 6-minute car ride, 3 kilometers, to a community hospital known as Alexandra Hospital that is part of our health system. This has facilitated day surgeries to proceed at the community hospital, but also free up space for our oncological operations. This also enables time to be freed to further develop a partial nephrectomy. And during the COVID-19, our staff has more time to develop, in this case, a 3D imaging for our robotic partial nephrectomy using the HoloLens. And also, like many other centers, more papers have been published in terms of academic work. Then what about those oncological operations that are high resource intensive, requiring intensive care, requiring a longer hospital stay? And this is where perhaps the development of wearables to monitor health status can come in. And this has been shown in major operations such as radical cystectomy and urinary diversion. One of my colleagues, Pramit Katrapal, is a urology resident working in London, and he has done extensive studies looking at the multiple different variables, including the Apple Watch, on recovery. And then he has charted using these variables, showing be it average, minimum or maximum number of steps recorded correlates, reduces immediately post-op, but gradually recovers back to baseline in blue by 3 months. More importantly, he has charted that average steps as well as maximum steps differentiate patients who will develop a higher clavin 3 and above complications from those without complications or minor complications. Here you see the differentiation of these two groups of patients on the right in average and the maximum steps. So patients can be discharged earlier and be monitored carefully at home using these wearables in case they develop complications. If anyone's interested, please give a shout out to Dr. Katrapal and LinkedIn to further discuss on this. In 2022, we had the Omicron variant outbreak. After an initial peak, hospital admissions and the numbers of infections have come down. This is really in part due to an increase in the primary vaccination take-up by the population. In Singapore, by the beginning of April 2022, there were 2 doses given to almost 90% of our population. We therefore now have to think about a recovery and resumption of surgical services in the endemic phase. And here we've also published our plans for the recovery. And this has to be taken place in a phased rollout from phase 0, where only 30% of the cases are being done, to eventually phase 4, where 100% of the workload in the clinic, outpatient and operating rooms are restored. And this really depends on the current spread of cases, whether there's community transmission or sporadic cases, versus again hospital resource. And really this when you open up in a phased manner depends a lot more now on hospital resource situation than the transmission rate with improved vaccination. What is important here is keeping the hospital updated, and we have this situation update dashboard that is sent out daily. Importantly, this does not just have the bed occupancy rate and the number of emergency ITU hospital stay, but it also has here, as you can see, the number of staff with COVID or on leave of absence or medical leave. Because staff getting COVID is a has primary impact on whether your surgeries can take place uneventfully, and you have to look after your staff. Coming back to the theme of looking after your OT, not just the surgeons but allied health anesthetists and nurses. Only then can your recovery and resumption take place smoothly. So in conclusion, surgical services, I hope I can have shown can adapt to the initial global negative impact of COVID-19. These adaptations, initially locally, have led to innovations in patient care to enable us to resume our regular surgical practice. No sharing of best practices in a conference such as what you have will enable us to triumph this COVID-19 period into a positive long-term global impact. And with that, I thank you very much for your attention.